This is our first webinar, hopefully of more than one. This is titled COVID-19, Lessons from the Front Line, Telemedicine Outpatient Care. Let's see if I can advance the slides. Here we go. So the purpose of the webinar is to start to address a care gap. Here we're defining the gap as a lack of outpatient, truly evidence-based tools. We don't have much in the way of a true description of the natural history of illness in the outpatient setting, and we don't have truly validated risk assessment tools or clinical management tools to help us with our outpatient care. And we have sort of a unique opportunity here because in the telemedicine clinic, we've been gaining experience now with over 400 patients seen in the course of their outpatient COVID-19 illness. And some of the providers, and we've brought those folks on today, have seen more than 50 unique patients in consultation for COVID-19. So we hope to share our experiences and promote dialogue about the care of COVID-19 in the outpatient setting using telemedicine. The intended audience here is outpatient providers who may be managing COVID-19. It's not necessarily Emory specific, and we're not doing a literature review or generating a specific practice guideline with our discussion today, nor is it meant to cover specific internal workflows for these patients, but more of just broad information and sharing experience. So the speakers today, who are we? We're from the Virtual Outpatient Management Clinic. This is an Emory COVID-19 outpatient service. It's a new multidisciplinary program, and hopefully we'll do a webinar that outlines how this was created, involving people like Dave Roberts, Tina Ann Thompson, a number of administrators, nursing, and APPs. So this virtual clinic is offered to all patients who have a positive COVID-19 test result at an outpatient setting or possibly at an ER setting at Emory, and patients can choose to have these consultations. And then after the initial consultation, they'll receive follow-up phone calls throughout their symptom course to help them manage the symptoms and watch for clinical worsening. We're seeing that patients are doing well. So far, when we've looked at the first 400 patients, it's less than 10% who are hospitalized. Obviously, some of them are still being followed and still early. And within our program, if a patient is doing worse, there are different ways that we take care of them. They can see us or their primary care doctor for a telemedicine consult. They can come to the in-person respiratory clinic, or they can go to the emergency room as needed for care. So I give you that background so that I can introduce the people who are contributing to this talk today. There's myself. I'm an outpatient primary care physician at the Paul Seavey Internal Medicine Clinic on Clifton Road. And I've done the clinical guidelines work to get this started in consultation with a number of other people in the group. Next, it'll be Dr. John Mazer. He's a colleague here in the clinic and a well-respected primary care internist here at Emory. His main role has been doing initial consultations for patients when they've received the COVID diagnosis. Next, we'll hear from Michelle Chalai. She's a nurse practitioner in our practice, and she has done multiple things, including initial visits for patients, some follow-up visits for patients in the virtual clinic, as well as the acute respiratory clinic care and the screening clinic care. Next, we'll hear from some of our advanced practice providers from other clinics who joined this effort as part of the follow-up call teams. That includes Colin Johnson from Emory's Bariatric Center at Midtown. And previously, prior to Emory, he worked in general and trauma surgery in Chicago. And he's one of the co-leads for the APP team. And then we'll hear from Leila Kutan, who is with Emory Otolaryngology Head and Neck Surgery, previously worked in a family practice clinic, and she's on the APP team that's calling and following up our high-risk patients. We have no conflicts of interest. This is not a CME, but we figured we'd include that note. So I'll try to briefly give context by describing our risk assessment tool, just so that you understand why we're seeing the patients and then how we're following them. This tool was developed to start the clinic based on this guidance that we got from the CDC about home-based care, which basically stated that we should look at each patient on a case-by-case basis, depending on their clinical presentation, their ability to be home monitored, and the risk of transmission within the home. It stated that all patients needed to be closely monitored, and that we should look at risk factors for progressing to severe illness, including age and comorbidity. So what we ended up doing with this is we have an initial visit, and this is what Dr. Mazur and Michelle and others have been doing as an intake video visit. They place the patient into a risk category 1, 2, or 3, and that determines the follow-up call frequency and duration. So from every other day in the low-risk pool to twice a day by the APP team in the high-risk pool. And again, these patients can be seen in other settings if needed. I'll move quickly through this slide. It is posted, and we can share it in other ways, but it was to give you a sense of the pools, just so you understand. Our low-risk patients are young and healthy, have relatively mild symptoms, and are doing fairly well. And that's the brief summary of the low-risk folks. The intermediate risk folks may be in their 60s. They may be younger than their 60s, but have one of these moderate risk factors below the yellow bar here. Or they may be a young and healthy patient who's not getting better and has persistent fevers or a worsening cough with mild chest symptoms. So it's meant to capture people that should be called daily. And then the high-risk pool is older adults over 70. It's folks with multiple risk factors, or this set of high risk factors that we took from the available literature. Again, not terribly evidence-based, but based on available data. And it was really trying to catch the patients who had either very high risk of worsening or already had lower respiratory symptoms, but not needing hospital admission. And so that's the basic starting point, was these risk tiers, and that's where we started when we began calling the patients. With that, I'll hand off to Dr. Mazur to see a little bit about what he's learned by speaking with these patients. John, just let me know when you need me to advance the slides.
Oh, thank you. Thank you, everyone. Thank you, Dr. O'Keefe and webinar attendees, for your attention and attendance today. My purpose in speaking today is to share some of my impressions of telemedicine from the perspective of a long-time, old-fashioned office doctor who's now adjusting to a new environment like most of the rest of us are. Next, thank you. First slide, Jim. In assessing telemedicine, I tried to figure out what the intent was, and I think the intent, either on purpose or just what comes along with the territory, is that we are adding a human face to whom someone can relate during a time of isolation and illness. We ourselves obtain an audiovisual representation of the patient's condition. A picture does say 1,000 words, and we have a memory of the patient that we can form in a general impression. Also, we make relevant the detailed paper questionnaire that they fill out or that we help them fill out online. So we do have an association with the patient when they fill that out. It's a good way to review their concerns about food and shelter, because most of them are in isolation. And I think it also helps us to facilitate coordination with the RN and the advanced practicing nursing staff, most of whom we've not really gotten to know over the years because we're all from so many different areas. But it gives us a common thread, their telephone contact with the patient, our visual, more detailed contact with the patient. Next slide, please, Jim. Okay, so our process, or my process anyway, there's no handbook on this exactly. What I've tried to do when I meet them and we finally get Zoom to work, because sometimes speaking takes a little time to get down, but when we get that going, first I assess their pain level, the respiratory status. I like to see that they can speak in complete sentences without any dyspnea, and I like to figure out what they're able to do at home. Some people are really bouncy and moving around, and some people are just in bed and not moving, and things like that. In my case, and not for some of the other practitioners, few of mine have had pulse oximeters, and many of whom have not even had thermometers since all of the buying craziness started. So we need to try to ask questions to figure out how they're doing. But I think the key, like in any patient that I see in my clinic or I've ever seen, in the first 10 seconds, I try to make sure I realize whether or not they're well, they're sick, or they're very sick. And sometimes very sick can be obvious. A lot of judgment calls were made by appearance, how spontaneous the patient is, what kind of respiratory effort they put forward, how clear they respond, really just their general energy level, something that I look at over the years. And I think you can apply that to telemedicine. I also, importantly, during this phase, reassure them that we're going to be following them and that somebody is going to be on their case, which is very reassuring. Next slide, please, Jim. And as part of our construction here, Dr. O'Keefe wanted to solicit whether or not we'd come up with any pearls or any surprises. And one of the surprises is that you would think in patients that are being managed over the phone or visually, that everybody does great. But some of these patients do worsen over 1 to 2 weeks of calling, and it's really an evolving art knowing which of these patients to refer for further follow-up for the acute chest clinic or whether or not the ER. Some people can have problems a week into their course, which is not what I'm used to seeing in outpatients generally when they're said to be stable. I found that over-the-counter medicines usually have been fine for the minor complaints that they have, be it nausea, cough, and headache has been a problem. Ibuprofen, we're shying away from a bit, although some of the literature now says that it's okay. That's a bit of a quagmire. Maybe some of the other practitioners will address it. Worsening dyspnea in the home, particularly if they're asthmatic, is the biggest red flag that I've uncovered. And the younger patients really seem to be a lot better off than the older ones, unfortunately, as it seems from I see. The other thing for the doctors, beware of your ergonomics. It's not really hard to spend 8 hours sitting in front of your screen. Next slide, please, Jim. So my conclusions are that telemedicine allows you to journey into the home environment of an ill, very contagious patient who would otherwise be out of view. So that's a unique change. You must realize limitations of telemedicine. I believe it's easy, or it's somewhat less hard to identify sick patients, but deciding how to manage them visually is difficult. And perhaps that's something that we'll get better at. The majority of these patients, as Dr. O'Keefe said, are appropriately managed by telemedicine. Next slide, please. And worsening respiratory status is the main red flag that I think we should all be looking for. I think favorable patient outcomes will determine the success of this method. I think as we continue to refine the tier process and risk factor assessment, we will get better at it. And I think in time, we will standardize the nurses' responses to what they see, and we will perhaps even develop an index of knowing which patients are in trouble. That concludes my remarks. Thank you very much for your attention.
Thank you, John. And we will, if we have time at the end, we can solicit questions, but we'll move on and ask Michelle to speak next.
Hi, this is Michelle. Next slide. So I'm going to be talking about the, can y'all hear me? Okay, I'm going to be talking about the lessons learned from the patient experience. One thing that you often find with these patients is that they're very scared. They're afraid of the diagnosis. Oftentimes they don't want their family to know. They don't want their family to worry about them. Some have expressed fear of being ostracized by their coworkers. Some have just expressed shame at the diagnosis. Others, go back a slide, please. Others have been worried about their outcomes. Can y'all hear me? Because this is saying I'm muted. Sorry.
That was my fault. That's Jim. Everything's fine. We can hear you great.
Okay, thank you. Sorry. They're worried about their outcome. Are they going to get sicker? Are they going to require hospitalization? Their family can't visit them. Of course, they're worried about death and who'll take care of the others. There's a lot of anxiety that you're seeing in their faces. If they're not expressing it to you despite you asking, there's just rapid fire questions, one after the other, where you can't get a word in edgewise, or they're asking a lot of, well, what if? And you answer it, and well, what if this? And so as you provide them more information and the reassurance John mentioned that the team is going to be following them very closely, you see them relaxing shows in their face, relaxation of their shoulders, releasing of the deep breath, and then usually by the end of the visit, they're thanking you profusely for what you're doing. Next slide. What I've been surprised, my experience, especially in the beginning, was that patients, I did have multiple patients with pulse oximeters, whether they were healthcare workers that already owned them, a family member had one because of some other health condition, or a family member was worried about this particular person, went out and purchased it, and the person has it to use. But patients don't necessarily know, number one, how to interpret the findings, and number two, don't realize that not all home pulse oximeters are created equal, and there's a lot of literature out there saying that they're really not that accurate at times. So a lot of it was having the patients put the pulse oximeter on and trying to talk to them about what we were seeing. So not allowing them to just brush things off as being attributed to some other health condition, talking with them about proper use. And at times putting the pulse oximeter on, finding patients that were tachycardic to 110, 120 when they would get up and go get a thermometer, I would ask them to do that. Finding out that despite them insisting they were afebrile, they actually were febrile, so tachycardia, and they don't feel like it, they don't look like it, they don't look bad. And then a few also were very hypoxic and didn't come up with deep breathing. One patient in particular referred her to the ARC immediately, and from the time I was speaking to her, within 12 hours, she was intubated in the ICU. So even though we know they're not necessarily always highly accurate, it's better to assume that it's COVID and have them referred either to the ER or to the ARC and be wrong versus attribute it to something else and have something unfortunate happen at home. It's also important to realize that there is a lot of misinformation out there. I did unfortunately encounter one woman who was tested positive. Her husband and her mother told her that COVID-19 was a hoax and that her quarantine was ridiculous. So this patient did not have any social support. She insisted, regardless of their answers, the family's response, that she was going to isolate. And so I did actually bump up her tier so that she would have increased support from the staff until she was feeling better and beyond the window of our fears that she would get worse. Next slide. With the patients, we know that approximately 20% are going to require significant follow-up. And a lot of people hear, well, 10 to 14 days. But really, with comorbidities, this can go on much longer. The symptoms linger, they change. And I've seen asthmatics, not that the asthma is requiring them to be hospitalized, but that they have, it seems like, an asthma exacerbation that persists for 3 to 4 weeks. So again, we want to trend the vital signs. This is something the patients can do at home, asking them, not just asking them to check their temperature, their pulse, their oxygen if they have it, but actually having them write it down. So we have some objective data to look at if things do turn in the wrong direction. Next slide. And then I found that in terms of symptom management, that intensifying seasonal allergy treatment has been very helpful. We all know allergies can cause cough, congestion, and so if they're normally well controlled on Claritin, I've been bumping them up to something more like Allegra and Flonase in order to take that out of the equation as to whether or not their COVID issues are getting better. As a nurse, I had instituted breathing exercises with some of the patients that had some respiratory symptoms, the proning, incentive spirometry simulation, and this does also help them to relax. Next slide. I also think it's important that we communicate with other services. In Dr. O'Keefe's document on management, there's for asthmatics increasing the inhaled corticosteroids up to quadruple. And when I've sent increased frequency to the pharmacy, they've questioned it, and it's only taken a quick phone call, a discussion about COVID, and they get it through. It's not been a problem. Also, when I'm doing these calls, video visits, I keep these phone numbers at hand, the mental health referrals and the ARC. And then the final slide this is the checklist that I use for the virtual visits, because there's so many, next slide, so many legal points that we have to hit, and I don't want to forget them. So I use this. I don't put names or phone numbers on it. I literally just one patient, one column. I go through, put in check marks. This helps me at the end of the visit. I can just take a quick glance. Did I cover everything? If I did not, perhaps read the disclaimer, I'll go back and make sure I get that done. So thank you.
Thank you, Michelle. So let me go forward. Okay, so here we have the portion given by our follow-up team, Layla and Colin.
Hey guys, so Dr. Keefe, you can skip to the next slide. So some of the things we're going to talk about are the pearls that we learned caring for the patients that are high risk via telemedicine and the follow-ups. Next slide, please. So one important aspect of this was continuity from the providers. We felt this was very important in terms of just seeing the subtle changes with our patients. When you have providers that are following up, you're noticing changes such as speech, cough, just changes in any type of symptoms, whether they're improving or whether they're worsening. And it really helps build confidence with these patients. The patients start getting more comfortable with you. As Michelle pointed out, these patients are extremely scared, extremely anxious. And so helping build rapport with the same providers really has helped us care for these patients better in terms of just them sharing their symptoms, sharing their family aspects of the situation with us and what they're going through. Next slide, please. So home vital signs was also extremely important for us as well. Patients that did have devices, they were more than happy to use them, and more patients actually did end up having devices more than I expected them to have. And using these devices just helped us with our roles in terms of diagnosing our patients with whether they had hypoxia or if they had elevated blood pressures or low blood sugar levels. That helped us, but then it also helped the patients in terms of participating in their own health. Using these devices also helped us distinguish whether these are symptoms from COVID or whether these are symptoms from their chronic illnesses, such as hypertension or diabetes or other chronic illnesses. And these devices actually helped us reassure our patients that they're okay, whether they needed to be escalated to the ARC or needed to be sent to the ER. Next slide. Colin?
Yeah, I'll take over here. So risk stratification, this is something that everyone should do with their patients the first time they see them. I don't know, it doesn't matter if you're in our setting or not. But go ahead and label them as a mild, moderate, or high risk, so that next time you follow up with them, you are knowing what to expect and kind of have those expectations as far as how quick you should act on their symptoms. Write it down and make it more real. And then it could also carry on through whoever else might interact with them, whether it's a nurse or an APP. The second thing is, I know we talked about that age and comorbidities, but one thing we've learned with COVID is you can't assume anything. A 30-year-old with asthma can be having the worst time of their life, whereas an 80-year-old with coronary artery disease, kidney disease is doing fine. So you really have to kind of have your highest suspicions during this patient interviews as far as any kind of symptoms they're having. And it's misleading. We've had patients with really no respiratory symptoms, but you put a pulse ox on them and they're in the 80s. And just like Michelle mentioned, we've had to send a couple to the ER and they've been intubated within the next 12 hours. So don't let the age fool you. 30-year-olds, 20-year-olds are getting significantly sick with this. So don't ignore these symptoms. And they do progress at the second week, and then they seem to return again at the 21-day mark. Next slide, please. I can't say enough about caregivers. When you talk to your patients, identify who they have around them to help out. This, of course, helps assist with maintaining their isolation, get some groceries, medications, but it's also an amazing point of contact that we've used. So one, they can give you a baseline for the patient as far as how they seem from their point of view. Two, for your older populations whose hearing might not be very good, sight might not be very good, use of technology might not be very good, their loved ones, friends can help them with phone calls or anything to maintain the point of contact. And these situations can change quickly. It's not like 2 or 3 days and you're getting worse. It's a matter of 12, 24 hours. So if something needs to be done quickly, they can have their caregiver there. They can drive them to the hospital or call 911 for them. If we can't get in touch with the patient through the phone number they give you, having that extra point of contact for us to call and see if they can get in contact with them has been helpful multiple times. And of course, having some around always lowers anxiety. We have patients who live alone, and although their symptomology from a clinical standpoint is moderate, the way they perceive it is much more severe because they don't have anyone with them, and it makes them much more anxious about everything. All right, next slide, please. All right, communication, this will kind of play off of what Michelle's talking about as well, as far as knowing what's available. But first of all, for providers, there's a lot of unknowns with COVID. We're all learning at the same time. It's only been a few months that we've been dealing with it. So having colleagues you can talk to bounce ideas off of, and to kind of make sure your plan of care is appropriate has been a great help for us. We've had the MDs and our entire APP team who we are quickly reaching out to kind of make ourselves a little more comfortable in an often uncomfortable situation. And also know your resources. Thankfully, Dr. O'Keefe and his colleagues have put together a wonderful handout for us as far as the quick reference guides. But also, you should also know the facilities around you. So if your patients aren't doing well, where do you send them? You always have to be ready for that next step. And one idea behind this is that if you know where to send them, the idea is you can hopefully prevent exposing people that are also, out in public or at ERs, so you can decrease those risks of exposure. Thankfully, we have like the ARC, and we call the ER ahead of time, let them know the patient's coming, or any other place you kind of send these people. So know your resources, reach out to ERs, respiratory clinics around you that might be a little more specialized and be able to handle the isolation precautions for these patients so we don't expose the general public. All right, next slide.
So what we noticed with our patients is that nights are extremely long for these patients. During the nighttime, symptoms are usually worsening with cough, fevers, headaches, and shortness of breath with chest tightness. So what we kind of just educated our patients about is that expressing to our patients that nights can extremely be long, they can be rough and extremely scary. So pre-medicating yourself is extremely important. Our recommendation to a lot of our patients was to take 1 gram of Tylenol before sleeping, keeping an inhaler at the bedside, taking an antitussive or guaifenesin. Over-the-counter sleep aids really help, such as Benadryl or even NyQuil, that really helps with their symptoms at night. A lot of these patients feel extreme lethargy. They feel extreme fatigue, especially at night. And what I can say from my experience is I myself had coronavirus. I couldn't agree with more of these symptoms. The way I kind of treated myself with the extreme lethargy and just overall all the symptoms is taking Tylenol just with a routine, every 8 hours taking Tylenol, doing honey teas and turmeric teas, taking Dayquil every 4 to 6 hours, along with steaming for congestion. And overall, myself included, usually a lot of these patients just feel better the next day after these symptoms just worsen throughout the night.
All right, so this has been a fun challenge for us. There's all kind of local shortages. You've tried to prescribe one inhaler or all of it, so ask a very similar pharmacy or prescribe a different one. Know the kind of list of different cough suppressants that are out there. And a lot of patients respond well to things like honey. So if it applies to them and they're not, raging diabetic and like that, they can definitely help. Tylenol can be hard to come by as well, so make sure you think of places that are traditional stores. So gas stations have medications, places like Big Lots have medications like Tylenol. So be ready to kind of recommend these more non-traditional stores. We've also noticed that some of the home O2 delivery for patients who've been discharged from the hospital has been delayed a couple of days. I'm not sure what's being done about that, just more of a point to be aware of. Even the other thing, like thermometers. We've had a patient whose friends have been to every store and can't find a thermometer. But you also, check the places where you would look for them. Look in the infants and children's section. They often have thermometers there. God forbid if those aren't available, you can look into the fertility section. They do have the basal temp thermometers for women checking for fertility. The accuracy might not be exactly the same as a regular thermometer. And always remind them they can ask their friends and family. There's no problem with having a thermometer, wiping it down, and using it while you have COVID. And pulse oximeters, I think, are pretty rare to come by in public now, so it's all back order on Amazon. So just be aware that although it's very helpful, it may not have it. So you'll have to make clinical decisions based on without that. And PPE, masks are highly important. We try to stress it as much as possible. People, I know it's hard to come by, so always there are people making masks that can be easily obtained. So Remind your patients that they're not alone. Reach out to their friends, their caregivers, their loved ones. We'll all be usually more than willing to provide any kind of shortages. Thank you.
So this is Jim O'Keefe. You can send us any questions or post them to Yammer. I recognize we're out of time, and so out of respect, we'll wrap up. I've left a quote up here that we found somewhat inspiring in this effort, as thinking about these are not hospitalized patients, but this is what we're trying to do here. Thank you, everybody, for your time.